It's an example of a pitfall when evaluating a portal vein in this patient with cirrhosis. At 3 megahertz, you can notice that there's little blood flow going into the portal vein, raising the suspicion for portal venous thrombosis. Switching this Doppler frequency to 2 megahertz, we managed to fill the vein with nice color signal, avoiding the diagnosis and false diagnosis of portal vein thrombosis. Another patient with portal hypertension with cirrhosis. If you look at this slide, initially this interrogation was performed with a very high scale demonstrating that there is no evidence of flow in the portal vein. The impression was complete occlusion or thrombosis of the left portal vein. Now, improving the sensitivity of this slide demonstrates that there's a flow in the portal vein, but it's reversed. So this is portal hypertension and not portal vein thrombosis. Another pitfall that can be encountered when you get biphasic flow, you need to make sure that you do not interpret any biphasic flow just based on the pattern you encounter as cirrhosis or portal hypertension secondary to cirrhosis. This is interrogation of the portal vein in a patient who is known to have tricuspid valve regurgitation. So this pattern can also be encountered in patients with right side heart failure and patients with tricuspid valve disease. Also remember that if you identify isolated gastric varices, make sure you don't think of portal hypertension, think of splenic vein thrombosis. The etiologies can be many. However, don't jump to the conclusion that this is portal hypertension. And another point that is important is clinicians many times ask you to evaluate the splenic vein for thrombosis. Unfortunately, ultrasound is not a great tool to do that. Why is that? Because you need to interrogate the whole length of the spleen, which is not really accessible with sonography. So presence of flow in a splenic vein does not exclude a splenic vein thrombosis. And always look for little hints. Look at the liver texture and surface. It's nodular, there's cirrhosis. Look for signs of recanalized paraumbilical vein. Check if there is enlarged spleen or not. Another example of portal hypertension. You can see in this patient, when you look at this study, you would say there is a flow going completely hepatopetal in this left portal vein. But if you notice carefully, the enlarged hepatic artery indicate there is some decrease in the portal venous flow going into this liver. And you can see in this tiny anterior branch of the portal vein, there is reversal. So that tiny reversal indicates that there is element of portal hypertension in this patient. So the complete combined color picture of the main vein and the arteries and looking at the flow in all the branches can help you to establish the right diagnosis and not miss the possibility of reversal of flow as in this instance. Now, vascular complications of acute pancreatitis can be evaluated with color Doppler. 30% is seen without necrosis, 57% with parenchymal necrosis. So the most common veins or vessels involved are the portal vein, the splenic vein. Now remember, you're going to get cavernous transformation of the portal vein as a result of occlusion or thrombosis of the portal vein. The arteries that are involved with acute pancreatitis commonly are the splenic and the gastroduodenal artery. Now remember, the presence of aneurysms will increase the morbidity and mortality in these patients. So attention must be made to exclude the presence of these vascular complications. This is an example of cavernous transformation of the portal vein in this patient with acute pancreatitis. You can see chaotic vascular structures with disorganized pattern of color indicating tiny little veins as a result of occlusion of the portal vein. This is another example of a patient with acute pancreatitis who has multiple short gastric varices. Look at the liver surface. The liver surface is smooth. There are no signs of cirrhosis. So this is isolated. This is a sign of isolated splenic vein thrombosis. Another example of vascular complications of acute pancreatitis. This patient with acute pancreatitis, as you can see, presents with a large pseudoaneurysm of the GDA, partially thrombosed. Color Doppler helps us to identify the feeder, and this will eventually end up going to the interventional suite for embolization to treat this complication. Another example of complication of acute pancreatitis. If you look at this grayscale image on the right-hand side, you would see there's nothing or no abnormalities of interest to you. But when you use color Doppler, you can easily identify that this cystic structure here is actually an pseudoaneurysm of the splenic artery. Color Doppler also can help us to look at tumor vascularity. It can help us to identify, characterize those. But remember, both malignant and benign tumors can have increased vascularity. This is an example of a patient who presented with right upper quadrant pain. Incidentally, we look at this liver and we can see fatty liver. The sonographer convinced me that this is most likely a fatty sparing area in common location anterior to the portal vein bifurcation. As you can see, that's the portal veins here. Then we decided to go and evaluate this with colored Doppler, and to our surprise, we managed to identify that there is a feeding vessel here in the center coming off the portal vein and feeding this mass. Subsequently, the patient went to MRI, and this has been proven to be a hemangioma.